Start time. So welcome to week 3. Talk about where we're at and where we're going. Just as some reminders, make sure, just be reminded that these sessions are recorded. Even during the break time, the recording is still playing. So just make sure if you are, responding, that you're off of mute. But then if you're not, just make sure that you turn your mute off because these sessions are recorded. In the event that you cannot be on camera, if you have to step away to use the restroom, or if you're having connectivity issues or any other issue, please place a message in the chat to myself. Send it to me. If you lose connection, just make sure you log back in. If I lose connection, just stay right there. I'll try to log back in on a different device. We do know we do still having these different weather events and the heat. You just never know with this connectivity. Make sure that you change your name so that it matches as it appears on Fortis's roster. So let me pull up our course here. So this is week 3. So next week is week 4. For sure, if you just have this class, you do have an exam on next week. If you're taking at least 2 courses for the most part, you're probably going to have 2 exams. I'm going to share my screen here. So be thinking about what that's going to look like for you. Share the time. Be thinking about how you're going to divide the time up so that you can, get all your study time in, spending time with the content. We will start the exam reviews. So make sure you attend those. At a minimum, make sure that you go back through the classroom recordings and also the exam review links if once they're provided. But if you can attend, go ahead and attend those as well. So we're in week 3. We do have some NCLEX questions that are due. We will take our quiz at the end this week. This will be the last quiz we'll take at the end. After this week, we'll have the weeks that we do have quizzes, they will start being at the beginning. The first 2 quizzes we usually have at the end, just to give you time to still get acclimated and adjusted. So we will take the quiz at the end. Next week, we have exam 1. And like I say, for the most part, if you're taking more than 1 course, more than likely you're going to have 2 exams next week. So be thinking about what that's going to look like for you. Make sure you divide the time up so that you can spend, equal amount of time with the concepts. And also be thinking about whether or not if you need that exam proctored on campus. It does require that 72-hour notice. In addition to that, make sure you have your IDs. Also, no paper can be used. You can use that clear sheet protector or a dry erase board. And once you finish your exam, you have to show for the recording that you've erased that sheet protector, which is just a clear thing, a clear plastic vinyl thing, and also that dry erase board erase. So just keep that in mind. You don't need a calculator because you have one inside of exam stuff. So make sure some campuses have dry erase boards, some don't. But ask your professors, they may have one of those clear sheet protectors. Your campus deans, they may have them, or the library, they may have those. If you're one that's needing, something to write on. And if you don't need that, that's fine, but no paper can be used. There will be a practice exam. Make sure you go in and complete that. It has not been set up yet, but make sure that you complete it for all of your courses, just to make sure that for one, especially if you change a section, make sure that your section is correct, and also that your computer specifications are matches exam software, because you will not be able to download that exam. And just remember that exam is usually open an hour prior to class time. So, you can go in and get that exam downloaded and have that set to the side. So once you log in for class, that you're not trying to download it. And if you run into problems, you have time prior to, and so that you won't be distracted. Because, if you run into issues, because you just never know. Exam software is really good though about working through issues if we have them. All right. So let's go ahead and look at some content here. So let's just see, activate some prior knowledge and just see where we're at. We do know we have a quiz at the end of class, and then we also have an exam next week. So I'm going to try to be quiet on this Kahoot and then just see where we're at, and then we'll review some information based on the results of Kahoot. So make sure you're reading the Kahoot and answering based on what your understanding is. Don't try to answer to be the, to gain the points, to be the fastest answering the question. But read and ensure that you're answering based on your knowledge or understanding of the concept. So I'm going to pull it up here and share my screen. So log in at least with your initials at a minimum. Let's see here. Where is it at? It's wanting to share our Zoom screen instead of our Kahoot. Okay, let's see. Okay, here it is. Okay. All right. So at a minimum, log in with your initials. The PIN is 193647. I said I was going to be quiet, but remember, a person of faith, they do have different names. If you minister, pastor, bishop, shaman, they have different names. So just remember that part. Okay. So a test taking tip is if you know what other concepts are, but you might not know what one is. So if it does not match, for example, if you knew what ethnocentrism was and this does not match that, then you know not to select that. So you can think of, even if you don't know the concept, but hopefully you know the concept. But there's still some ways that you can eliminate some of the answer choices. Well, I do know what ethnocentrism is. This doesn't match. So okay, I'm not going to select that one. I do know what stereotyping is and so forth and so forth. So I'm not going to elaborate any more than that, but just be thinking about that. But hopefully at a minimum, you know the concept. But sometimes, we run into some terms that are almost alike. So, but how can I eliminate some choices? If someone says that they are spiritual, remember another test taking tip, look for those words that will even make this. Remember, an answer choice about a concept has to be entirely correct. So look for those small words that will make the answer choice incorrect. I'm not gonna give it away. Remember, individualize, individualize, individualize. Got it. So again, I would encourage you to make sure that you're going back through the classroom recordings. Let me stop that. Kahoot here. Okay, so now let's look at the information in a different way. So, of course, I reviewed it on the classroom recording from last week. Like I said, hopefully you all are going in, looking at that, making notes, and also reviewing your required readings. So let's just look at that information. Now, let's do it whole group. So from current size. So let's talk about what is stereotyping. And you can come off mute or you can place it in the chat. Let me share my screen here. We were discussing what's a one word or what a phrase, or how do you remember what is stereotype?
Judging.
Okay.
Like if one person does it and all people of that nature do it.
Okay. Great. So essentially, we're making assumptions. Stereotyping occurs when someone attributes certain beliefs and behaviors about a group to an individual without giving adequate attention to individual differences. Remember, we provide that individualized care. So no matter if I attend that church, or if I go to that I attend that organization's meetings, or I attend that organization's events that they have, we shouldn't assume that just because I go to that church or I go to that organization's meetings or events that I am whatever, fill in the blank. So making those assumptions and thinking one way about a person. So again, stereotyping occurs when someone attributes certain beliefs and behaviors about a group to an individual without even doing a head-to-toe assessment, having that asking those questions and getting that subjective and objective data. We just assume, we just make assumptions. That's stereotyping. So critical thinking, we're critical thinking all the time because we want what? We want positive outcomes or negative outcomes. Positive outcomes. So critical thinking is outcome based, and we're all the time thinking. But when we're in doing that head to toe assessment and we start seeing those abnormalities, we taking that blood pressure and we're seeing that the blood pressure is low or either high, is out of range. We're trying to think, okay, what do we need to do? What do we need to do to get this blood pressure back to normal? We're going in, we're finished taking care of our patients. We're thinking, hey, our outcome is this patient does not fall. We're letting those beds down to the lowest position. We're putting the call lights in reach. We're all the time critical thinking because we want to have those positive outcomes. It's outcome based. And hopefully our goals are met. And while we're critically thinking and we see that our goals are not being, the outcome is not being met, it's negative, we're, trying to come up with ways, well, how can we reevaluate what should be done? So critical thinking is outcome based. Hopefully we have those positive outcomes for our patients. We're always thinking through what's next, what's next. We're trying to prevent problems from happening. So if someone says they're spiritual, and you can come off mute or you can place it in the chat, what's a sentence or a phrase or one word that you can use to um, discuss or give us an example of what someone means when they say that they're spiritual?
They believe in a higher power.
Okay. What else? Okay, so they have deep beliefs, they have deep values that guides that person, and it connects them to some type of higher power. There's some type of connection. So, what is this philosophy of individual worth? What is all of that about? Again, come off mute or you can put it in the chat, but just come off mute so we can hear you. Philosophy of individual worth. What is individual? What is worth? What is philosophy? Break it down. What are we talking about? What does the word individual mean?
Self.
Okay. That person unique is that own person's idea. And they're unique and they feel valued. So each client is unique and has value regardless of their differences. And we want to observe that. And that, remember, that client has the right to live according to their personal beliefs and values, as long as it doesn't interfere with the rights of others. Now we'll talk about when we get to talking about spirituality, where a person might want to refuse medication or treatment. It's still that individual's right. They're unique to refuse that treatment, whether or not it's medication or some type of treatment. But that's still part of them being unique. And we are, it's like autonomy too. Philosophy of individual worth. You can kind of think of it as autonomy and respecting that person's autonomy. But each client is unique and they have unique values. And but regardless of that, we still are going to provide that best care for that client. And then the other piece is, long as whatever their uniqueness is not causing harm to others. Like we mentioned about the person of faith, we do want to include that in a patient's care. That's part of being culturally competent. And so just as long as those practices, like for example, sometimes they'll want that person of faith to come in and they'll want them to pray. They may even want them to do some type of ritual with you know, a cloth or some type of herbs and things like that. But as long as it's not causing us any harm and them any harm, we include that in that client's care. Okay. So this slide says, discuss what should be considered in planning for a client. And and this should say culture. We're considering their culture. So what are some things that we need to be considering or thinking about if we are going to include their culture in their care? So we want to include, I already said this, kind of started the conversation, but we want to include those practices that are not harmful. So what if a client wants us to include something that is harmful? Do we want to include that into the client's care? No, we don't. We want to repattern or get them more information so that they can maybe hopefully change whatever that practice is, because the point is if it's harmful or not. If it's not harmful, we do want to include that. But if it is harmful, we want to repattern and get them to change that out. Discover the client's health police, discover the health police of the client. We want to find out more about our clients. And that's going to come from, you know, us doing that head to toe assessment, talking to them, establishing that therapeutic relationship. We'll find out more about our clients and the things that they believe. And because we just talked about that philosophy of worth, of the individual worth. So we do want to include those things in their care. We want to preserve practices that are helpful. You know, if they're wanting to pray, you know, every hour, they want that person of faith to come in and perform some type of ritual, as long as it's not harmful, we want to include all of that in their care. And that is considering the client's culture and being culturally competent. The whole idea is it harmful or not? If it is harmful, we don't want to include that in the care. We want to offer other options. But for sure, we're not going to include that in their care because it's going to cause us harm and them harm. All right. So in the chat, just put a T or F. I'm going to let you read through this before I talk. Just put a T or F. All true. So let me go back to the slide here. All right. So culture is a behavior that is learned by the members of the group, being passed down from one generation to another. It acknowledges the view of the world and others from a similar standpoint. And yes, this is true. And then the other piece of this being culturally competent, we don't want to stereotype. We still don't want to make assumptions, because even though the culture, the behavior is passed down from one generation to the other, sometimes each generation will change it up just a little bit. So again, that's why we don't want to stereotype and make assumptions because a person belongs to a certain group or they attend a or belong to a certain organization, that you know that we don't want to make assumptions about what they're going to do or what they're not going to do, Because even though things are passed down, that information is passed down, those practices are passed down, still sometimes from one generation to the next, it kind of changes up just a little. But that is true. Culture is a behavior that is learned by the members of the group, being passed down from one generation to the other. It does acknowledge the view of the world and others from a similar standpoint. Okay. So, how can we as the nurse become more culturally competent so that we can provide that best care for our clients? Because we know now that we have to include that in our patients' care. We want to include the things that they value in their beliefs in the care. So, how can we become culturally competent? What do we need to do?
Understand other individual cultures, other individuals' culture.
Exactly. We need to have that conversation. When we're doing our head to toe assessment, we need to ask those things like what are those things that we want that you want to include in your care? First, we need to assess, well, what do they know about their disease process? Do they understand what it is and what it takes to manage it? And then learn to be flexible when what they value is different from what we're valuing. So, but remember, we're providing the care for them. So, if what they value is different from what we value, it's okay. We're providing the best care for that client, not the client providing care for us. We want to recognize, though, how our culture, our way of thinking, what is that? How do we think about culture? What are our cultural beliefs? So, having that understanding about what we believe, it helps us to understand our differences and also to be respectful of the differences as well. And then discover how clients are unique despite their cultural group. Talked about, we don't want to stereotype, we don't want to make assumptions and lump everybody in one group because they all went to the event that the group had last week. So we want to discover how our clients are unique despite their cultural group. Okay, let's see him. All right, so let's go back to this Kahoot, and I'm going to talk you through it this time. But hopefully, we we are there any questions about any of the concepts that we went over, which is the information that we had on the Kahoots. It was just seen in a different way. So this time, let's see if I can. Let's see. Um, let's see here. Do the I'm trying to get to the flashcards. Let's see. Let's see if it'll let me do the flashcards. Uh-oh. Let me just log out. Cool, log back in. Okay. Let's do the flashcards. Let me share my screen here. Okay, and you can tell me what to select by the colors. Okay. So here it is. Culture is what?
Red, yellow, and green.
Okay. So culture is passed down from one generation to the other. Remember that test taking tip, that one word can make the answer choice incorrect. So make sure that the answer choice is all the way correct. Okay, it's a behavior that is learned by members of the group and acknowledges the view of the world and others from a similar standpoint, but we still don't want to stereotype. Okay, so we did good on that one. All right, let's see. Delivering culturally competent care does include the person of faith, and they're called ministers, pastors, bishops, shamans, to perform various rituals. We want to include that in patients' care, as long as it's not harmful.
True.
Okay. Yeah, there we go. Okay, how can the nurse develop cultural competence? What can I do so that I am more culturally competent?
It's red, blue, and green.
Okay, recognize how my culture affects my thinking. What are my cultural beliefs? Okay, you said red. Then discover how clients are unique. Remember, we provide that individualized care. So we have to ask questions, learn more about our clients. You said blue, and then you said yellow.
No, green.
What makes yellow incorrect? What's wrong with this gold? Rigid is the opposite of being flexible. So again, when you first look at it, it almost looks like it's the same. Another test taken tip. It almost looks like it's the same thing, but rigid is not being flexible. When our values differ from our patient values, we don't want to be rigid because remember, the patient, we're providing care to the patient, but we do want to be aware of what our own cultural beliefs are, but we're not going to not take care of our patients because what they believe is different from what we believe. So this being rigid makes this part incorrect. Okay. Patients, differences are observed. They have the right to live according to their personal belief. What is that? Is that stereotyping, ethnocentrism, culturally competence, or philosophy of individual worth? The patients are different. They're unique. We provide that individualized care. They have the right to live according to their personal belief. Which of these is the
Red.
red? Philosophy of individual worth? Because we said stereotyping was making assumptions. What's ethnocentrism? What's that word right there? Ethnocentrism. It's when what? A
When you
person.
think your ways are better.
Exactly. So remember that test taking tip, we can look at the other concepts of the answer choices and say, well, I know it's not this because ethnocentrism is thinking that their way is better than anyone else's way. We said stereotyping is making assumptions, having a belief about a cultural group or a person because they went to the organization's event or they belong to a cultural group. Good. Okay, which should be considered if someone says that they are spiritual? What are they talking about? What does that really mean? Do they have deep beliefs or no beliefs? Go ahead.
Blue.
Beliefs.
I heard blue and I heard beliefs. Is that it?
No, I was saying it's beliefs, but the answer is blue.
Okay, just blue. Okay.
It's blue, red, and yellow.
Okay. So it is beliefs. It is not no beliefs. That's why I thought you were saying it was beliefs. So that's why I selected red. So beliefs deep values, deep beliefs, and then that connection with that higher power. Okay. There are few religious faiths practiced with the majority of them being a Christian faith. Is this true or false?
False.
What word makes this false?
Majority.
The not majority.
It's few.
It's few. Yes. So it is, there are a lot, a bunch, whatever word is the opposite. Few is a lot of, is more. What other words we can use for that's the opposite of few? There's a lot of, let's go back to it so we can make sense out of it. Okay, there are a lot, a huge amount, a large number of religious faiths practiced with the majority being of Christian faith. So this word right here makes this incorrect. And I was just throwing some terms in there that would make it true. So again, when you read an answer choice or read a concept, make sure that the entire thing is true about that concept, because the word few make this incorrect, makes this false. Because in actuality, there are a lot of religious faiths that are practiced, with the majority of them being Christian faith. Okay? Each faith has its own premise, and each member has an individual belief system. Is this true or false?
True.
Okay. Critical thinking, what is it? Is it assessment only?
Red.
Okay, it is outcome based. We gave you all those different examples. You know, we're all the time critical thinking. We're trying to have, you know, we want to have positive outcomes for our patients. So it's outcome based. Remember, it is once we implement those interventions on that section where we're evaluating, we're trying to see was our goal met. Those are our outcomes. And we hope those outcomes are met, that those goals are met. And if not, we reevaluate and see what else needs to be done. Okay. So stereotyping is, while ethnocentrism is.
Green.
Okay. Stereotyping is making assumptions, while ethnocentrism is my thinking my way is the better way. So while this is, again, just taking to make sure that it aligns with what you're trying to actually say. This is actually flipped. And so just make sure that you are, oh, then selected. Okay. I think that was it. We did pretty good on that one. Any questions about that? So all of this information, of course, will be on your quiz and also will be on your exam. And remember, we reviewed it initially at the end of the recording. So again, make sure you're going back through your classroom recordings. Make sure you're going through your required readings and completing the assignments. All of that information and all those different things, those tasks, they coincide, and it helps you to better understand what the concept is. So no matter how you see it in a scenario or a question that outright asks you to define something, that you're able to answer. Okay, so let's go ahead and finish the rest of our content for this week here. So we kind of, last week, we started Nurse Lisa and Nurse George. They started talking about the nursing process. So let me share my screen here. So what are those 5 parts of the nursing process? And we say ADPI to help us, is the acronym. What does that stand for?
Assessment, diagnosis, planning, implementation, and evaluation.
Okay. So Nurse Lisa and George want to return to nursing school. They're discussing the nursing process. You know, think about what happens during each of these. You know, what are we doing? Uh-oh. Okay. So ADPI, the ADPI is the acronym used for the steps of the nursing process. Like she just said, assessment, diagnosis, planning. You know, what are we planning to do? And then the implementation, that's that to do part. That's where we actually give the medication, administer the IM injection, actually insert the Foley catheter, and then evaluation. We recheck the temperature. We go back and recheck the blood pressure. Did it get better? You know, we gave the antipyretic. We gave the medication so that's supposed to lower the temperature. So we go back and check and see that it helping. We administer pain medication. Did it help? ADPI is the nursing process, is an organized way so that we don't forget anything, so that we can easily identify what each client needs individually. So even though we have 5 patients that have diabetes, we still want to provide that individualized care. We want to meet their individualized healthcare needs. Okay, so the assessment is that first step. This is where we're gathering that information. We're having conversations with our clients or our patients. We're looking through their medical records. We're looking at lab reports. We're gathering information about the patient's health status. And that's everything from physical, their social, their head-to-toe assessments, it's all of that information. Then that information is used to come up with an accurate nursing diagnosis. We know NANDA has this list for us. So for example, and then of course, the registered nurse will decide which, nursing diagnosis or, priority. Of course, we're going to take care of the whole patient. So we will have several care plans. We may have one on unstable blood pressure. We may have one on decreased cardiac output. We may have one on self-care deficit. So there may be several. The assessment stage is also the opportunity. This is where we can establish that rapport and gain that trust of that client. And it kind of, it shows that we care. Now, we're not following policies and procedures, but this is like a one-on-one. So it allows us to build that trust with that client. And it also allows us to be culturally competent. Remember, we talked about discovering those things that our clients want to include in their inside of their care, or the things that they believe. This is the opportunity to get that information from them so that we can incorporate it in their care if it's not harmful. Remember, we want to repattern harmful practices, but we do want to include practices that are not harmful in their care. So let's see this little bar. Planning, develops a plan of care for the client. Consider the patient's health problems and needs, as well as all the resources available. And I know we're going to get to this at the end. If we have a patient that's being discharged, who on the healthcare team helps us to identify resources that are available? For example, if the client needs oxygen concentrator, hospital bed.
Caseworker?
What'd you say?
With the caseworker at the hospital?
Caseworker, what's another word that we call them? What's another type? Social worker or caseworker, yes. So we want to consider the patient's health problems and needs, as well as all the resources available. That's part of planning for them. Because we want, when does discharge begin? When do we start thinking about this client being discharged? On what? On admission. So it may change, those discharge things that they may need may change, but we start thinking about, because remember, that client's not coming here to stay. They're going to return back to home. Whether or not that's an assisted living facility or their home or living with someone. So we start thinking about it on admission. We want to involve that patient in that planning process because we want to be culturally competent. We want that client we want to include their preferences and the things that they value. No matter how many patients we have with diabetes or hypertension, we still want to provide that individualized care. So for the most part, when the facilities buy those products, and there are a whole bunch of different systems out there. So when they buy those products, those electronic health records, they click on, diabetes, everything from A to Z about diabetes is there. So, but we have to go in and eliminate or take away or only select the things that apply to that patient. That's what make that care plan individualized. Okay. And then we want to include the client's cultural preferences. We want to assess what, well, the previous stage, we've already assessed what they know about the disease process. And we want to consider cultural and religious beliefs that may impact the care. We will talk about spirituality here in a few, but what if our client is death is pretty much imminent? No, we don't know when death is going to happen, but based on our assessment findings, death is pretty close. And that client says, "Nurse, I need you to baptize me." Can we baptize that client?
No. No, you can't baptize a client, but you can get them.
And when we say baptize, we're not talking about the traditional, maybe like, you know, placing a person's whole body in water. It could be sprinkling. There are variations to baptism. So with that being said, if death is pretty close, can we, the nurse, baptize the client?
I say no still because you're not a spiritual like. Don't you need like a degree to do that?
We can. If the whole point, the death is imminent. So we can, as a nurse, that's part of that spirituality. That's and that we'll get that and when we look at the spirituality slides, but we can. I know you're saying like we're not that person of faith, like that minister, that shaman, or the bishop or something like that, but we can as the nurse. Remember, we're that respected profession. Nurses can do no wrong. Nurses is the answer to everything, so to speak. We really can. Implementation, that's the doing part. So if we were to ask you, which of the following interventions can the nurse perform? Think about all of those skills that you practice in the skills lab that you more than likely have to get checked off on. And then once you got to clinical, you are administering medications. You are administering IM injections or sub-Q injections. You are inserting those Foley catheters. All of these are skills and things that we can do. The implementation part is carrying out or skills that we can perform. And those skills that we had to learn, for example, to administer the medications and get checked off on, that we do under the guidance of our clinical instructor, we will not delegate those tasks to an unlicensed personnel. And we'll talk about delegation a little bit later on. While carrying out the plan of care, monitor the patient's response to the treatment, because remember, we're going to do that evaluation part where it's outcome based. So did this work? Did this help the client? So we want to monitor the client's response. An example, in our assessment, we took their vital signs. We noticed that they had a fever. We noticed that the blood pressure was elevated. One of our interventions that we implemented was administering Tylenol or some type of antipyretic, ibuprofen, or it was some type of blood pressure medication. So we're monitoring the client's response. We're going to recheck. First of all, I'm going to back up. If we get an abnormal blood pressure or temperature, what do we do for that finding? Do we just automatically go with that finding, or do we verify it and recheck first?
Recheck first.
Okay, we recheck, we verify it. So now we verify this client really does have a fever, that the blood pressure really is elevated. We've administered the medication or whatever the intervention actually was. We've implemented what we needed to do. So we monitor the client's response, because what we're getting ready to do, we're gonna have to evaluate. We're gonna recheck that temperature. Did it work? Did the pain go away? Is this patient in less pain? Did the blood pressure come back more toward normal? So doing evaluation, during this stage, the nurse assesses the patient's progress and determines whether the plan of care was effective. Changes are usually made as needed based on the client's responses. So that's that ADPOC. Okay. So Nurse George and Nurse Lisa, we've talked them through the nursing process. So here we go. Who does what? So, which of the parts of the nursing process do the LPN function more independently?
Planning.
Implementation.
Trying to move this part out the way. Okay. So, the assessment part, when we go in and we do our head to toe assessment, we're checking those vital signs. The assessment part, we function independently as an LPN, and then the implementation part. RN doesn't have to be there for us to administer that medication unless it's initially and it's something that's new for the client. But if it's something just routine, so doing the assessment and the implementation parts of the nursing process, we as LPNs function more independently during those two phases of the nursing process. Oh, and that I got to hit myself. Does the LPN function in an independent role in the nursing process? So the LPN functions in an independent role in the nursing process by collecting data. That's an assessment. Assessment, collecting data. We're saying the same thing. And implementing or doing interventions, performing interventions. All that's saying the same thing. Okay. The LPN functions in that independent role by collecting data, assessment, and implementing. The RN creates the nursing diagnosis. This is NANDA, that NANDA list. The LPN collaborates with the RN on the plan of care and evaluation of the client's outcome. So remember, critical thinking is outcome-based. Safety is going to be priority. We're all the time thinking about the client's safety. Remember, in the hospital setting, urgent care, doesn't matter. We want that client to not have any injuries. Remember, if they're in the hospital setting, for the most part, they're connected to all these different cords and IV lines. They're hearing sounds that they wouldn't normally hear. The lighting might be different. So we want to make sure that those beds are in the lowest position. Call lights are in reach. Safety is going to be priority. Before collaborating on the plan of care with the RN, the LPN must assess the client's understanding first. Remember, we want to gather what information, what does this client know about hypertension? You remember, we're healthcare professionals, so we're studying, but if a person is not a healthcare professional, they might not know what hypertension is or diabetes is. So we want to assess and find out, what do they know? What is their understanding? Do they understand what it takes to manage their disease process? And then if that client decides to refuse a treatment, then we acknowledge that and we still continue to monitor that client. Okay, here we go. Nurse George asks, then who does the patient teaching? RN does the blank patient teaching. The LPN and the
RN does the initial teaching.
got it. Okay. So then the LPN is going to reinforce. I'm sorry. I'm telling you the answers. Go ahead.
The LPN is going to reinforce.
And what? Collaborate with
Collaborate.
the RN. Yep, got it. Good. So the RN does the initial. We can, as LPNs,
Remember this lady.
we reinforce. And then we collaborate with the RN. Yes, great. So Nurse George states, do you know? So he asking us two questions. The first one is, the LPN will most often reinforce the client teaching and notice changes needed to the plan of care during the implementation phase. So this is Nurse George is saying, hey, we're going to be doing this reinforcing this teaching. And when we're in implementing, administering medications, putting in that Foley catheter, doing a dressing change, whatever that intervention is, we're in there doing those things. Is that when we notice, hey, that this may be working or it's not working? Do we notice those changes? Is that true or false?
True.
Okay. Nurse Joyce asks, nurse interventions are patient specific for what the nurse will do to assist the client in reaching goals and the identified outcome. Is that true or false? It's true. So nursing interventions, remember, they're specific. No matter we have 5 patients that have hypertension, they're still going to be specific to that patient. Patient in room 201 may have diabetes and they're pregnant. Patient in room 202 may have diabetes and they're having a hip replacement. The next patient may have diabetes and they have type 1. The next one may have diabetes and have type 2. And they're coming in because they have COVID. It's still patient specific. Okay. So let me go back. What are those 4 terms that the United States Department of Education uses to describe what we do as the LPN? What are those 4 terms? Judge, recognize, determine, and appraise. Gotta know these 4 terms, you all. Out of all the things that we do, we're that most trusted profession. We can't do any wrong. We can baptize patients if death is imminent. We do a hit-to-toe assessments. Out of all those things we do, they came up with 4 terms that say, all of those things that you all do will fall in one of these categories. And we need to know those 4. So nursing in the 21st century. So they have these nursing shortages. We still have them. But as a result of it, the LPN was recognized by the National League of Nursing. That's what this NLN is, National League of Nursing. They say, hey, wait a minute. The LPN is just as an important part of the healthcare team as the physical therapist, as the RN, as the social worker. So they put their stamp of approval on us, on our role. And also because of that, guess what? Our pay increased. So as a result of our pay increasing, the pay between the RN and LP, it narrowed. It's not that big of a difference. And then also nursing programs, they've changed. You just don't sit Monday through Friday in a brick and mortar. We have online and brick and mortar. We have part-time, night, day. It's a mix. So nursing programs, the way that they look, they have changed as well. You need to know these things, you all. Almost to our top of our first hour. What is subjective and objective data? If you were trying to explain to someone, what's your phrase or your one word that helps you know the difference between subjective and objective? And you can come off mute and tell me.
Subjective is what the patient say it is, and then objective is what we collect.
Okay, so this is the nurse, and this is the patient or the subject. Okay, so my pain is a 7. Is that correct? I feel nauseous.
Yeah.
I'm hungry. This is what the subject or the patient is saying. I feel sad today. Objective. These are vital signs that we, the nurse, have collected. We have observed what the skin turgor is. It readily reforms. What color is it? Cyanotic, ashen. What does that wound appearance look like? We've measured it. It's draining. Whatever it is that we observe from that wound, all of that is objective. And also, when we are determining the patient's level of consciousness, we're trying to see if they're oriented. That is objective as well. So these are the things that we are collecting. And these are the things that the subject or the patient is telling us. All right. Let's see. We at the bottom of our first hour. And we will pause here and go on a 5-minute break. We'll see you in 5. Just a reminder, you all, this recording is still on, so make sure your cameras are off and you're on mute. All right, that 5 minutes went by pretty fast, you all. Let's go back. Come on back in. Okay, so we talked about the nursing, how it has changed over the 21st century. We talked about the nursing programs changing. We talked about the National League of Nursing, how they recognize that the LPN is just as important as any other team member. And as a result of that, the salary, our pay, it narrowed between the RN and the LPN, the difference in pay. And we talked about the different roles, the things that the LPN and the RN can do. What are those two parts of the nursing process that the LPN can do independently? Well, they're not an independent practitioner, but they go in and do these things independent. What are those two things?
Assessment and implementation.
And what's another word for assessment?
Collecting data.
Got it. Good. And what are those four terms we talked about? Out of all the things that we do so many things as a LPN, practical nurse, but the U.S. Department of Education has summed it up in 4 words. What are those 4 words?
Judge, determine, appraise,
Recognize.
yeah.
Okay. So we were talking about things that we can do as an LPN. Can we do a dressing change or change a dressing for a wound?
Yes.
Can we insert a Foley catheter? Can we remove a Foley catheter?
Yes.
Can we administer medications to clients that are stable?
Yes.
Yes.
Okay. Good, good, good. All right. I think, let me see, did we get a little bit further? Let's see here. Just reviewing the things the concepts that we just went over. Let's see. So, fall precautions, safety, like I mentioned before, safety is when we talk about safety, it's all things safety, but the most thing we think about is preventing that person from falling. If they have a condition, their blood pressure is unstable, if their electrolytes are off, meaning their sodium can be up or down, potassium can be up or down, they can be dehydrated. Safety is going to be an issue. We want to prevent that client from falling. So we're all the time implementing fall precautions. For the most part, in those hospital settings, they have those bands. In some long-term care facilities, I've seen them have like little trees or apples by people's names on the door and things like that. But at a minimum, safety. And we're trying to prevent people from falling, because the complications from someone falling, that can actually lead to death. And so it is very important that we consider safety. So we talked about assessing that client's knowledge of their condition. Do they know and understand what this condition is that they have? So we do want to assess their knowledge, because it could be that they just don't understand what that disease process is and the things that are needed in order for that client to manage that disease process.
I'm sorry. Are we supposed to be looking at a PowerPoint?
No, we were just reviewing what we just did on the PowerPoint. So I'm giving you the same information in different ways so that you can identify quickly. Okay, I know what she's talking about. And then you all are responding. So these are the things that we just looked at on the PowerPoint. I'm just recapping. So those things that you still kind of struggle with, go ahead and be starting your list, because those are the things that you're going to want to start with first when you're going back and looking at your, starting your study or your final look at your concepts. So we talked about the options on a care plan. Care plan should be standard or individualized. Which one?
Individualized.
Got it. So remember I told you about the products that facilities buy. So with that being said, when that care plan is pulled up, would every option apply to our patients, or every option might not apply? Would it apply or would not apply?
Would not.
Okay, so not every option would apply for our patient, because we talked, the example that I gave you were all the patients that had diabetes. And so, you know, their care is going to look a little bit different. I think we recapped everything. All right, so let's move forward here. Let's get back to our slides. We left off with subjective and objective data. Okay, and let me share my screen here. From current slide. Okay, so we talked about safety, all things safety. Okay, so what are some things that we should be considering? What are some areas the nurse can provide safe care for a client that is complaining of being lightheaded? What are some things we need to be thinking about?
Precaution.
Got it. Those non-skid socks. We want to provide assistance if needed. If they have an assistive device, cane, walker, crutch, we want to make sure those things are in reach. We want to put that call light in reach. And also be monitoring those vital signs. Good. So put it into concept. We're talking about safety still, but now this patient's 3 hours post-op, which is going to look a little bit different if that person was 5 days post-op or 3 days post-op. This patient's 3 hours. So we might have to administer this anticoagulant. We're going to be monitoring for pain, vital signs, and we also may use these compression devices. What about respiratory difficulties? What are some things that we need to be thinking about in the realm of safety?
Provide oxygen.
Okay. Oxygen therapy. Elevate the head of the bed. Change that position. Get that person up. If something happens in the middle of that bed, that person gets in that little slump, and then in that little middle part, and those lungs cannot expand like they need to. So elevate that head, reposition, do deep breathing exercises, encourage the use of that incentive spirometer. They don't like those little things. And then of course, if they need oxygen, you know, we can put that oxygen on. They may even need breathing treatments. Now, think about safety. Our patient has had a left mastectomy 5 years ago. Okay, so we don't want to use that side, that extremity. So to check blood pressures or to do blood draws. Just usually have a sign as a reminder, or something, or the sign may have a picture or something with the X on, whatever, left or right. So it will remind us, hey, don't check the blood pressure on that with that extremity, and don't draw blood on that side. Okay. Got it. Here it is. We're just looking back at these again. All things safety. The person's dehydrated. The person's just came in because they've been admitted with pneumonia. Fall precautions, keeping that patient safe from falling. When collaborating with the registered nurse, plan of care outcomes should be measurable, realistic, and time specific. So if we are trying to decide which outcome we should select from the selection from A, B, C, or D, or if we're having a conversation and we're trying to decide which of these, we want to make sure that as much information is there as possible, that is realistic. Whatever the outcome is it something that's realistic for what's going on with the patient now? You know, is it this patient, or it may be a different patient? But we want to make sure those things are measurable. Can we determine, is there a measurement that we can use to, or some type of scale that we can determine whether this is getting better or worse, and time specific? So you want as much detail as possible. Okay. All right, let me hear from you. Which care plan will provide the most comprehensive care for the client? Individualized, a standardized, generalized, or a non-specific care plan.
Individualized.
Okay. And that would be correct. All right. Client-centered relationship centered care. So we're focusing on that client's needs. We're including their preferences. We are competent. We are culturally competent. So we are aware of what we think and feel about our culture. Our culture beliefs does not influence us taking care of the client, even if what they believe is different from ours. We want to include those cultural practices if they are not harmful. If they are harmful, we want to repattern those harmful practices. We don't want to include anything that's going to harm them. Make sure that we're being respectful. Okay. Communication can be closed or either open. So usually closed questions usually ends up with a yes or no. The open, we kind of get more information. It gives us, we have more detail. Can you describe your pain? Whether, if we say, do you have pain? It's pretty much yes or no. But if you can describe it, oh, it's in the right leg at the top part on the front. And it did, it hurt when I put my foot like this. So you'll get more detail with open communication. What is this S bar? Again, it is a way that keeps us structured and organized as we are communicating. So the S bar, when we're talking to the healthcare provider, when we're talking about the situation, it is the why. Why are we calling? What is the reason for the call? So, and the reason for the call could be this patient's had a change in mental status. This patient has fallen. This patient is refusing their medication. This patient was administered the wrong medication. So it is the reason for the call. We want to tell them who we are, who we're talking about, and what the reason why we're calling. Okay. So the background, they need to know that many diagnoses, like, because remember for this right here, we're on the phone usually talking, or either we're sending some type of communication. Usually they're not in person, but even if they are in person, we still, it's just they just have that brief amount of time and you're at bedside and talking about this client. What is their background? Why did they come in? How long have they been here? What are their vital signs? Example is patient came in 3 days ago with congestion. How is the congestion? Pain? Are they on any new medications? Do they have an IV? Are there any allergies? So what are our assessment findings? Patients complaining of pain, they're rating it as a 4. It's radiating to their back, their neck, their jaw. What are those assessment findings? What you think is going on based on the data findings? We should collaborate with the RN as needed. Here's what I found. What do you think? And again, is doing the assessment part, is this life-threatening or not? And then the recommendation part, these are the goals of the care. What needs to be done, including the consult? Are there any new medication orders? Is this patient going to be transferred? And think about, too, what is needed to diagnose? What is needed to help the patient? Recommendations also include, we need to get a urinalysis. If an x-ray needs to be ordered, what are those things that we need to do to find out what is wrong with this client? That's like another way of kind of saying recommendations. Okay. This is just all of it put together, saying the same thing again. So we're changing shift. We can use S-bar 2 to change shifts. Again, it's that structured way of communicating. Some things we kind of leave out when we're just changing shift, though. The situation, when did they come in? What was their chief complaint? Their diagnosis. Background, if they have an IV, where is it? What do they have hanging? Is it hip lock, or do they have IV fluids actively infusing? What's their cold status? And then assessment. What happened during your shift? And then recommendation, what needs to be done. Healthcare is 24/7. So we have to go home. The next nurse may have to, obtain a urinalysis, call the labs in to the doctor because you just got them in. It's a continuity of care. What are those things that needs to be done to help take care of this patient? Okay. Active listening, the most important part of communication, particularly therapeutic, health-related communication. Therapeutic communication is that interaction, the sender and the receiver. And this is part of establishing those therapeutic relationships, and we show that we are letting that client finish what they're saying uninterrupted. And we use those positive techniques to verify what the client is saying, to clarify what they're saying. And active listening is needed. And one technique that we're kind of not so easy with is just being quiet, being silent. If that patient is not ready or their family member is not ready to make that decision, it is okay to remain silent. So these active listening techniques, restating is just repeating what the client said in a slightly different way. As in paraphrasing is repeating, but we're putting it in our own words. And then clarifying, you asking the question in response to the patient's statement to be sure that we understand. Because sometimes what is being communicated, sometimes there's a mix-up, and what is actually the intent sometimes is not what that what we receive. So we do want to use these active listening techniques. To summarize, we want to state the main idea.
Yeah, why you put fucking pepper on the floor?
Got it. We want to make sure that we are getting the information from the clients as they are really conveying it to us. Just as a reminder, you all, these sessions are recorded. Make sure that you're on mute. Minimum encouraging. Go on, and we can even use a gesture. The patient's talking, we're motioning our head up and down. That is positive. Okay. George and Lisa are trying to come up with open and closed-ended questions. Discuss, indicate, open or close. So, what were you doing when your stomach ache started? Is that open or close? Which one? Open is we're going to get more detail. Close is
open.
Open.
Okay. What time did your stomach ache start?
Closed.
Close.
You pretty much just get that time. An hour ago, this morning, after I ate. Would you rate your pain on a scale of 0 to 10?
Closed.
0, 5, 10. You just gonna get that answer. Got it. Good. All right. So, what is the difference between clarifying, restating, and paraphrasing? So these are usually the ones that are kind of really similar, but so we want to make sure that we are good on these. So I'm going to take my time and read through this slide. So clarifying, asking a closed-ended question in response to a patient's statement to be sure we understood. So close. Patient says that their chest hurts. So the nurse asks, tell me exactly where your chest hurts. Right here. They may point, or they may say on the left side or the right side. Okay. Restating. That's repeating what the patient said in a slightly different way. Patient says, my chest hurts and I can't sleep at night. So we're restating. We say, you have been unable to sleep at night because your chest hurts. So we're trying to make sure, we are understanding why they're not able to sleep. Paraphrasing, expressing in your own words what you think the patient means. So the patient says, I don't think I am being told the truth about my condition. And the nurse says, you believe you have not received all of the important information about your health condition? So usually these are the three. So make sure you look at the examples and be able to tell the difference between which one is which. Clarifying, restating, and paraphrasing. Positive communication. Again, being aware of our body language. You know, folded arms. You know, are we glaring eyes, or are we making that eye, establishing that eye contact, looking away? But that sustained eye contact, leaning in with glaring eyes, is not positive. But briefly establishing that eye contact, looking away, making eye contact backwards and forwards, keeping our promises. You know, we say that we'll bring their water pitcher back with ice in it, or we will return in an hour to check on them again. Just make sure we're doing that. And even if we can't, make sure that, we may delegate that to someone else, or we may ask the person, we change a shift and we say, hey, I told them, I just gave them this pain medication. I told them I would check on them in an hour. We're changing shifts. Be sure to go in, but keeping those promises. Factors that will affect communication. The situational is a biggie. That environment, that noise. Remember, if they're in the hospital setting, they're hearing these bells, these whistles, these alarms going off. And if we're in trying to do a head-to-toe assessment, if they're in pain, this situation, that noise, even if we're doing a dressing change, and we're trying to talk to that patient, we might want to see what that facility's policy is, especially if we know that dressing change, that wound has an odor to it. Most facilities have some type of something that refreshes the air, whether or not it's opening the window or putting out the little peppermint oils or whatever it is. But the situation does influence our clients' communication with us. Sometimes they shut down, they don't respond. We're coming in asking questions. When I'm trying to do a head-to-toe assessment, they're not responding to us because they're hurting. They're hearing all these sounds and things. They don't know what's going on. They're afraid. So that situation is a biggie with hindering communication. So then we have negative communication. And the one that we kind of falter to is giving advice, because the patients, we've established those therapeutic relationships. So they trust us. So they don't mean anything by it, but they tend to say, well, nurse, well, what would you do? But we don't want to give advice. We do want to make sure that they have enough information. If we have to bring in the dietitian back in to talk to them again, bring that healthcare provider back in again to clarify some information or to give them more information, that's what we'll do. But we don't want to give advice. We always want to put it back on the patient because it's their decision and we are going to support it. That's usually the one that kind of gets us, is giving that advice. All right, so here we are, knowledge check. According to the text, women often end sentences with questions while men make what? Apologies, declarations, jokes, or guesses?
Declarations.
Okay. And we agree. Belittling, judging, non-assertive behavior, and assertive and probing. Okay. So let's go over here. The statement, you must eat salads every day as to why you are that size. So we're thinking about these right here. Let me go back. So just, to be thinking about which one of those match. The next statement says, you must don't do anything at work. Your hair is in place all the time. The other one says, you must eat the wrong foods to need this test done. So for example, the patient comes in and they need, blood drawn to check their cholesterol level, or they come in and need a stress test done, whatever, they're getting some type of procedure done. And we're saying, hey, you must be eating the wrong foods is why you need this particular test done. And then the statement, the patient in room 201, you would like to use the patient in room 201 as George. The nurse is everything. Ask George, is everything going to be okay? George tells the patient, no need to worry. Everything will be okay during surgery. Remember, we said that we don't do that. We don't give that advice. Okay. So Craig, the nurse, told the patient in room 201, I think you should save your questions about your condition for your healthcare provider. Again, we're still looking at these terms here. Susan asked one of her patients, what do you and your family do for a living in order to live like that? You know, is that probing? Is that
Probing.
assertive?
Probing.
It's definitely not assertive. Yes, it's probing. Got it. And then let's see, I think I have some more examples. The statement, you must eat salads every day as to why you are that size, reflects judgment. Judging a client has limited value and decreases the chance of creating that therapeutic relationship with your patient. So if we're saying your hair is in place all the time, you must don't do anything at work. You must need this test because you eat the wrong foods or you're not taking your medicines, anything like that. That reflects judging. George has told the patient that everything will be okay. That's false reassurance. We have no way of knowing that everything will be okay. Now, if that client needs more information to determine whether or not they want that procedure done or not, then we can, we'll have that healthcare provider to come back in. But we don't provide that false reassurance. I don't think that you should worry. It's not that big of a deal. That is belittling. Belittling includes downplaying the importance of the client's signs and symptoms or whatever it is that they have going on. I don't think you should worry about that. That's belittling. Okay, and we said that was probing. Probing occurs when the nurse pushes for information beyond what is medically necessary to know. We don't need to know what they do for a living in order to provide the best care for them. That's not part of it. That's probing. All right, this little bar out the way. Look at some more examples. Assertive responses reflect honesty, taking a positive stand, and being confident in a positive, persistent way. Okay, so we got two examples. So is this assertive or not? Greg, the wound nurse, tells Hannah, the other wound nurse, everyone is here today. I should finish in good time. I will be able to help you if you need me, if needed. And then the other statement says, Greg, the room nurse, tells Hannah, everyone is here today. You shouldn't need any help to finish in good time. I won't need to help you. Which one is assertive? Remember, assertive. What'd you say?
The last one is assertive.
Assertive is responding, reflecting in honesty, taking a positive stand, and being confident in a positive, persistent way. Is this being positive?
Assertive.
What'd you say?
The last one is not assertive then.
Got it. Because this one, it kind of started off okay, but then the person, this nurse is telling the other one, you should finish in good time. So yes. So be careful with that. Good. You caught it. So again, test taking tip. If the question is asking you about a concept, but there's a scenario, use that dry erase board or that sheet protector, or just think about what does this word mean, and then pick out the scenario that matches. And remember, it has to all the way match. So part of this match, but then the other part, this nurse is telling the other nurse what they should be doing. Good. Okay, so here's another one. Craig, the nurse, told the patient in 201, I think you should save all your questions about your healthcare condition for your healthcare provider. Routinely telling a client who asks about their illness, tests, medications, or treatment to ask their healthcare provider is non-assertive. Craig, the nurse, has the responsibility to seek answers, even if we have to bring that healthcare provider back in. So this is non-assertive. We're kind of passing. Remember, we said non-assertive was passing the buck, not really giving them an answer or a solution or resources so that they could come to an answer. Remember, we talked about posture, that leaning forward with glaring eyes, folded arms. That's aggressive. Keeping the arms open and not folded, and our hands not on our hips, but at our hips. That's a desirable position. So standing erect with the head held back, just a little bit, that shows that we're confident and in control. But that lean forward, those glaring eyes, that's deemed aggressive. Okay, so here it is. We got Nurse Lisa talking. Let's think how a person is displaying each one would speak or act. Let's see what we got. We just talked about it. Passing the buck is which one? Okay, here we go. What is assertive? We said assertive is being honest. So think about that. So here we go. Which style would be used to advocate for the patient?
Assertive.
Okay, we're being honest. Good. Which style is passing the buck?
Passive.
Or either non-assertive, yes. And then which style is confrontational? Leaning forward with those glaring eyes. Aggressive. Got it. Yep. Does anything contribute to workplace violence? Think about where you work at. Think about where the location is that you have to park. Think about what you're doing while you're at work. If you're having to take care of clients that may have a mental health crisis, that are combative, if they've had a head injury, if they are unstable diabetic, sometimes that level of consciousness changes with a person that is diabetic, and they can become combative. And so that condition of that client can put a person at risk for workplace violence. The location of the facility. I think the example that I gave was the facilities like right here, and then where they want the employees to park is a mile away. There's not good lighting. If you're working, that's a facility that stays open 24/7. What is the lighting? Can we see walking to that facility? Or is there personnel there that can assist us? A lot of some facilities don't have security 24/7. So think about all of these things that puts us at risk for workplace violence. What is the condition of that client? Head injury, diabetes under control. They're hypoglycemic. They're having a mental health crisis. All of these things could put us at risk for being injured while at work. Nurse Lisa and Nurse George, they assist with staff education. It is now time to do this month's staff education. This month's topic is sexual harassment. They create this worksheet to guide the discussion. What should you do if you are a victim? Okay. We want to confront. If we're the target, we want to confront that person who is harassing us, tell them that behavior is unwanted. Send a clear message. Be firm. Let's put this up here. So confront the person who is harassing you. Your assertive response is to tell the person clearly what he or she is doing is unwanted. Be sure that your responses are firm and assertive, being honest. Your message must be congruent so that whatever we're saying, that our body language, they match. We're saying, we're telling the person, no, what you're saying is not nice, it's unwanted, but at the same time, I'm winking my eye. So make sure that our body language is aligning with what we're saying. We talked about being culturally competent. We want to provide that culturally competent care. We want to identify what our beliefs are. We want to find out what our patients' beliefs are so that we can incorporate those practices that are not harmful into their plan of care. We want to be aware that there are differences in cultures. We don't want to stereotype and assume that You know, if someone's from one cultural group, that all their beliefs are the same. So enculturization is the process of learning your culture, the way the group does things. So that's just learning. That's what they call that, enculturization. So cultural diversity. So we want to consider, like we talked about, that eye contact. Sustained eye contact is considered disrespectful, but making eye contact, occasional eye contact, that's therapeutic. Touch, that's another thing we want to be careful. If we're touching, it's touch, like the shoulder, but other places, for the most part, we just keep our hands to ourselves. But touch is one of those that sometimes is not welcoming and sometimes it's okay. But you'll find that out as you talk to your clients, your patients, and see what their preferences are. Space, how close should we be to our clients when we're talking? They have that personal space. We don't want people in our personal space, and our patients might not want us all up on them as well. Some things, we'll have to be really close proximity to them, but for the most part, maintaining that personal space distance. So food preferences. Which healthcare team member are we going to bring in if we have something going on with the person's meal, food items?
Dietitian.
Everyone is important, and we will have to bring them in. So that patient's not eating, that patient's wanting food items that are not on the menu. If they're wanting meals at a different time, all things food and meal, we're gonna bring that dietitian in, and so that we can seek out information and give them resources and options that will align with their cultural beliefs, as long as it's not causing them any harm. So we kind of already talked about these negative effects on culture. We talked about stereotyping, just making assumptions. Ethnocentrism, my way is the only way. Whatever that person thinks, disregard whatever else other people think. And then, so prejudice is not treating everyone equally, as such as discrimination. But discrimination can be more so like based on someone's, if they belong to a cultural group, then we don't do something for them, or we do something for them because they do belong to a certain cultural group. Okay. So here we go. Getting ready to talk about the interprofessional healthcare team. It's more than us on that team, and it does take all of us working together to get that positive client health outcomes. But what does that really mean? So all of us on the healthcare team, we're working together. What that means is we're helping that client to be restored to their optimal physical, emotional, spiritual, all things, everything about that patient should be considered. Getting them back to their optimal level, as close as to norm as we can. If not normal, as pretty close to as we can. But we want to consider what their physical, were they able to turn, reposition, get up and walk by themselves. Their emotional, spiritual. We may have to bring in mental health professionals. We may have to bring in the person of faith, that shaman, allowing that person to do those rituals at that bedside, as long as they're not harmful. Restoring that optimal physical, emotional, and spiritual health in the client. And this slide just shows some of the healthcare team members. There's so many more. Okay, so let me hear from you. Which member of the healthcare team is responsible for assisting with client food preferences and helping us observe whatever those preferences are? Who's that person? Food, all things food.
Nutritionist?
Dietitian. Dietitian, thank you. Who is the healthcare member that assists with arranging community agencies and providing those resources? Patient going home, they need a walker. What'd you say? Social worker. They need a cane walker crush, a bit of a hospital bed. They need a concentrator. They need their medications delivered. So they identify that pharmacy that delivers. And so that is that social worker. Got it. Who's on that healthcare team that provides that initial patient teaching? Got it. Okay. What if the patient refused treatment? For example, they refused medications, they refused their chemo, whatever that intervention was, they refused it. What should the nurse's response be?
And try to educate the patient.
Okay. Anyone else? So we make sure they have all the information they need to make an informed decision. They have it. They're deciding to still refuse. What do we do?
Document.
Document and
Respect
what
the
else?
decision.
Respect it, document it, and we continue to monitor that client. It is important that we accept that client's right to their belief, their right to refuse, disagree. We don't want to change their mind, but we do want to make sure they have enough information so they can make an informed decision. But once they have that, they decide to refuse it. Right to refuse. We continue to monitor that client. We don't, even if like pain is a thing that sometimes you'll see. Patients will try to hold out either cultural beliefs, religious beliefs, whatever it is. Pain is one that you see often where they'll just say, well, I'll hold off on that pain medication. Sometimes they'll tell you, hey, I must be paying for something that I've done, or it's my cultural belief that I don't take pain medication. That's one that you see pretty often. But as long as you've informed them of everything, they have the right to refuse. We just continue to monitor them and continue to take care of them. We don't try to change their mind. What if the client asks you to pray for them or perform a baptism and death is pretty much imminent? Can we baptize them?
Yes.
Okay. Yeah.
Yeah.
If the client is gravely ill, like I said, we don't know when anyone's going to pass away, but based on our assessment findings, and they feel it as well, sometimes, and if death is pretty close, they'll ask you, to pray with them. Sometimes they'll ask you to get somebody, but if they're pretty much, if it's imminent, we can just go ahead. It doesn't mean that we're going to immerse the whole body in water, a pool or something like that. It could be just that sprinkling of water and just saying that prayer with them. It is important for the nurse to accept the client's right to their belief and neither agree nor disagree with their choice. We don't want to try to change their mind, but we do want to make sure that they have enough information so they can make an informed decision. So let me just stop right here and let's recap. Let me make sure I haven't missed any questions. Okay, good. You all have been responding in the chat as well as verbally. Great. All right, so let's do some recap. Let me ask some questions about the information that we have went over. Let's see here. Okay, I just asked you, can we baptize the client if we think death is pretty much imminent? You all did say yes. Patient refuses treatment. Do we want to make them do whatever the intervention is that we're trying to implement, or do we acknowledge that client's right to refuse and just continue? Got it. We acknowledge it and we continue to monitor. We still provide that doesn't mean that they're refusing everything. We still provide that best care. If anything comes up with food, even if it's related to their religion, if they just don't like a food, which healthcare professional do we bring in? All things food to help us.
Dietitian.
A dietitian. Okay. All right. Let's see here. Let's look at we had this on the slide. Let me just make sure we're all on the same page with this. I think nurse, if it was George and Lisa, they were talking, and the patient, George told the patient, you can just save all your questions for your doctor. They'll answer them for you. Is that passing the buck or non-assertive, or is that assertive?
Non-assertive.
Okay. Non-assertive / passing the buck. So they, mean the same thing. So yes. So George is not providing the information that he can, or seeking out answers, or bringing in that healthcare professional. He's just saying, hey, just save all your questions for your provider. They'll answer them. Not that he is, getting the healthcare professional, not that he's even trying to see if he has the answers to some of the questions. No, we're not giving our advice, but some of their questions we might have the answers to. Like if they're asking about their blood pressure medicines, we're administering those medicines, so we know the name of them. So they would need to say that for that healthcare provider. So that is being non-assertive or being passive. They're passing the buck, so to speak. So all those things mean the same thing. What if we are, the example in the slides were, is this judgment or probing? I think the example was, the reason that you need this test is because you eat the wrong foods. Is that judgment or probing?
Judging.
Judging, okay. What if someone, our coworker, is saying inappropriate things to us, or making gestures that are in the realm of sexual harassment? What's that first thing that we do?
Confront them.
Confront them. Tell them exactly. Confront them. Say, hey, this is not welcome. This is not how this is going to go down. Yes, we want to confront them. Okay. So we got that part. Any questions so far? But anything that we've went over? All right, let me give you some more questions. Just make sure we all on the same page here. Believe it or not, we've went over all of our content, but I'm just going back and just asking you the information in a different way. Let's see. Let's go over this S bar. Let's see. So we have called the doctor to tell them whatever's going on with our patient. We told them about the situation. So as part of background, so the reason why we call, let me just give you an example, a little scenario. Patient's blood pressure is low. Blood pressure is 80/40. So that's the reason, that's the situation, that's why we are calling. Of course, we tell who we are, who we're calling about. And so part of that background information, what do you think we need to include in there? Be in reference to that blood pressure. What's some things we probably need to include? Background.
Their history of hypertension.
What else?
Vitals.
What else? If they have hypertension, more than likely they're what?
On medication?
On medication. So we want to include what medications they're actually taking. So part of that background is not only that they have that diagnosis of hypertension, they take lisinopril, they're taking Lasix. Matter of fact, they took Lasix this morning, or they took their last dose of medication yesterday at 8 o'clock. That's part of that background. We're calling because that blood pressure is low. We're calling because that temperature is high, whatever that situation is. But a part of that background is, do they have a history of what's related to that problem? This time, this person's blood pressure was low. Well, sometimes blood pressure does run low if someone says hypertension. They may need that adjustment, or they may have some other diagnosis or something else that's going on, is why that blood pressure is running low. But we still need to include that this person has a diagnosis of hypertension, and also include what medications that they are taking. Because if that blood pressure is running low, why is it important to include that medication? Because more than likely that medication is going to be what? Given again. Do we need that doctor to know, hey, this medication, they're on this, has a diagnosis, they're on this medication, and it's due in an hour or whenever it's due again. Because that doctor more than likely will adjust, hold the dose. Sometimes they may even DC that medication altogether, especially if they're on more than one medication for that diagnosis. Okay. So recommendation. So go back to what you know recommendation is. We said that these are the things that we're going to do to take care of the patient, to decide what's wrong with the patient. So which of the following is a recommendation? The patient in room 201 has a diagnosis of hypertension. The patient in room 201, blood pressure will need to be taken in an hour. The patient in room 201 was admitted 2 days ago. Which one of those is an example of a recommendation?
The blood pressure.
The blood pressure is due in an hour. So yes. So recommendation are those things that we're going to do to determine what's wrong with that patient, to help that patient. What's another word or phrase that you all use to remember what the recommendation is? So let me just hear from you. How do you remember what the recommendations are?
Is that evaluation?
Like AdPad?
I heard evaluation. What was the other thing that you all said?
No, I was just asking if it has something to do with AdPad. Is that what you're looking for before I give an answer?
Well, it just, I'm just trying to see, and we learn from others, just trying to see how do you remember what the recommendation is. So what part of the AdPad would that be?
Implementation.
Implementation. Got it. Good. So you have a scenario of all these examples that I just gave, but the question is asking you to select which one of these is a recommendation. A recommendation are those things that we're going to be doing. So is that implementation part. So good. We learn from, remember, we're life learners. And so even though someone said implementation, someone said those things that we're going to be doing to help the patient to determine what's wrong with them, we're still saying the same thing. Okay. And let's see. Let's give you another example just to make sure. We called the doctor because the patient complained of left foot pain. We're talking about S-bar. What part of S-bar is that?
Is that assessment or situation?
So what is situation? Let's talk about it. Let's decide. So what is situation? Go back to your definition. Situation is what?
What the problem is?
The reason of the call.
What the problem is, why we're calling, the reason for the call. And what was the other thing that you all said that it might have been?
Assessment.
Okay, so assessment is what?
Collecting data.
Okay, so assessment would be a little bit more than the patient saying, we're calling because they're hurting. So the assessment part would be what? Right leg, it started when, it's on the front. It gets better when, they change position and all of that. There'll be a little bit more information. So if we are saying that we are calling because the patient is complaining of pain, that's going to be that situation, the why that we are calling. I know that those two, knowing that those two are kind of close. So you want to just make sure that you walk it back and ask yourself, why are we calling? That's the situation, the reason for the call. And then assessment is going to be a little bit more information. Because go back to AdPod. It's all of the information, that's subjective and objective information that we're getting. Okay. All right. So we're going to pause there and we're going to take our next break. what we have left is just a few more. We reviewed all the content. I'll ask you a few more questions, and then we'll have our quiz left too. So that's where we're at. So we're on break. We'll see you in 5. But remember that this recording still goes. So make sure that you're on mute. See you in 5. All right, so just a few more things before we take our quiz. Let me just make sure that, just going back over everything that went on the slide. It's the same information, just asking you without you actually seeing it. So it's the same information. So I think on the slide I said that I think the question was, men make declarations while women often end statements with what?
Questions.
Okay. And so it's the same information. I just asked you, I just flipped it and asked one or the other. So it doesn't change. Okay, so we're trying to enter the patient's room. You know, we get ready to implement. We're getting ready to administer medication, getting ready to do a dressing change. So, of course, we knock on the door, we provide the client our name. We identify ourselves. So they kind of are the same. We're saying, hey, I'm Nurse Lisa, student nurse, or Nurse Lisa LPN. So we provide the client our name and then identify ourselves. Like, are we the nurse? Are we the social worker? Are we here from the ethics committee? So we're saying who we are. So first we're stating, provide the client our name, and then identifying ourselves. The identify part is adding, what's our purpose for being there. And then we ask the client to state their name and their date of birth. And then we ask the client what they prefer to be called. And in the long-term care facilities, what they'll do is, like, if they have a nickname or some other name other than their legal name, they'll include that as part of their care plan, so that it's okay to call them that, whatever that their preferred name is. So we go back over that again. So we're providing the client our name. In addition to that, we're identifying ourselves. Hi, my name is Lisa. I am the nurse with I work in the social work department. I am the nurse, the wound nurse. I am, the nurse that's working with respiratory today, or I'm here to administer your medication. So we're telling them who we are and identifying, what our purpose is. And then we are asking the client to state their name and date of birth, even though that they have on a name band and all of that. And we'll go to that. If they can't state their name and date of birth, then, of course, we'll look at some other ways of identifying. But the norm is we ask the client to state their name and date of birth. And then we'll ask the client what they prefer to be called. Now, we talked about, and we're talking about communications, situations influencing communication. What's something, we're going in that patient's room, would this be a situation that would negatively affect the client communicating with us? We're doing a dressing change and the wound has an odor, or we're trying to do a head-to-toe assessment, and we're asking the client questions, but they can't hear us because all these alarms are going off. Would either of those be a situation that would influence that client's communication with us?
Yes.
Yes.
Yes. That situation, that noise, that odor, it can affect that client's communication with us. So sometimes we think about communication, we just think about talking, the sender and the receiver, but there are things, situations in the environment that can influence. That patient's in pain. We need to get their pain as controlled as possible. Then that patient will be more apt to communicate with us. So that's a situation that will influence that client communicating with us. So therapeutic communications, is offering advice therapeutic?
Can you say that again?
Therapeutic communication. So think about what therapeutic communications is. My question to you is is offering advice. The client say, nurse, what would you do? We're offering our advice. Is that therapeutic?
No. Oh,
No, it is not. We don't give advice. What about if we remain silent? Is that therapeutic?
yes.
Yes.
What about if we change the subject?
No.
That's not therapeutic. What about if we reflect or restate what the client has said?
Yes.
Yes.
All right, good. So it's the same information that we talked about it, but I'm just asking you in a different way. So remember, it doesn't change what you know about the concept. All right, I think we went over everything several times. So do not click the quiz because it's not set up yet. Let me go in and put the time and everything on it. And we're gonna take the quiz, and then of course we got our other 15 minutes at the end. So once you finish taking the quiz, then you're free to log off. But remember, use your time, read each question carefully, make your selection. So it's not available just yet. So hold on. Gotta go in and put some things there. All righty. Let me put an access code in here and we'll be ready to go in a few shakes. So don't forget the exam reviews at a minimum. I have not published the quiz yet, so don't click on it. Because you all are going to finish at different times. So I want to go ahead and just give the recap. Remember, you need your ID. No paper can be used. Get the dry erase board or that clear sheet protector. Complete the practice quiz. I will let you all know when it's available in ExamSoft. Make sure you go through it because you want to make sure that your computer is compatible and ready to go. If you need that exam proctored on campus, you need to send an email. Include the campus dean, myself, and Dean Brown in the email. It requires that 72-hour notice so they can get a place and a time set up for you. Because if it's proctored on campus, it's not going to be given this time of night. So just consider that. But we do want you to, have that available for you if that's what you need. What's the other thing? I think that's it. So we'll take our quiz and then you log off because we haven't taken our last break. So I am going to publish the quiz. I am going to place the code in the chat. Remember, you can find the quiz in the grade book and or on the modules. Okay, I'm publishing it now. So if you've already clicked on it, you need to refresh because you're not going to be able to see it. And I'm going to go on mute. If you need to communicate with me, please put it in the chat. Please don't come off mute if you have a question. Hold on, I'm going to push it out to everybody. And I'm going on mute here. You should see it published. And I'm going on mute. Once you finish, you can log off.